Hello and welcome to the ASCO Daily News Podcast. I'm your host, Dr. Monty Pal. I'm a medical oncologist, professor, and vice chair of academic affairs at the City of Hope Comprehensive Cancer Center in Los Angeles. Today, we're going to explore the evolving landscape of treatment strategies in head and neck cancer management, including locoregionally advanced head and neck squamous cell carcinoma, which happens to be on the rise in the United States, in part due to a spike in HPV-mediated oropharyngeal cancers. We're also going to discuss the emerging strategies of using blood-based biomarkers to really advance personalized therapy. Joining me for this discussion is Dr. Ari Rosenberg. He's a medical oncologist focused on head and neck cancer, and he's an associate professor, congratulations on the recent promotion, at the University of Chicago. The University of Chicago has really produced luminaries in this field, Dr. Rosenberg included. I've had the pleasure of getting to know Dr. Ezra Cohen over the years, who really had his grounding there, and of course, Everett Vokes, former ASCO president. I'm really looking forward to this conversation, Ari. Thanks so much for joining us.
Thanks, Monty. Thanks for the invitation.
You got it. And just a quick note for our listeners, our full disclosures are going to be in the transcript at the end of this episode. So Ari, let's start with the basics, if you don't mind. So head and neck cancers are very diverse and they're challenging, right? In the sense that they're near vital organs, the treatments, as we all saw during fellowship, if not now in clinical practice, they can really have such a major impact on vital organ function, speech, swallowing, et cetera. Can you just comment on head and neck cancers that are on the rise in the U.S.? I alluded to this briefly. Particularly, we've heard this in the context of colorectal cancer and so forth. Are you actually seeing younger adults being affected by this?
Yeah, thanks for that. The vast majority of head and neck cancers are head and neck squamous cell carcinomas, as I'm sure many of the listeners recall as well from fellowship or their current training. And as you alluded to, the organ function, long-term and functional quality of life outcomes are quite important, particularly in the context that these develop in high-value real estate, parts of our head and neck area that we use for speaking, swallowing, all sorts of other essential functions as well. As you also alluded to, we think of this in two different particular subtypes of head and neck cancer. The historical head and neck cancer from 50, 60 years ago was almost exclusively related to carcinogen exposure, tobacco, alcohol use, and that subtype of carcinogen-induced head and neck cancer has been slowly declining. However, over the last now several decades, we've been seeing an increase in primary oropharyngeal squamous cell carcinoma, mostly tonsil, base of tongue. These are attributable to HPV, human papillomavirus exposure, and that's now the majority of the head and neck cancers that we tend to see in our clinic. As you also alluded to, these have very different prognoses as well. HPV-related head and neck cancer has a much more favorable prognosis, where much of the interest has been in, can we de-intensify to optimize long-term function? But then the non-HPV-related head and neck cancer, or what we call HPV-negative head and neck cancer, continue to be very, very challenging. We only manage to cure about half of these folks, with many of these patients developing recurrent disease. These patients, in addition to being difficult to treat, also have major impacts, both in terms of the treatments they undergo, as well as their disease that can impact their function and quality of life. You hinted at this a little bit, but we have been seeing an increase in younger patients with HPV-negative head and neck cancer as well, which is quite concerning. Younger patients, oftentimes never smokers, never drinkers, who are developing non-HPV-negative head and neck cancer. And that's been a little bit of a more recent trend that we've been seeing as well. So definitely a lot of work to be done to optimize and improve outcomes across all of these different head and neck cancer subtypes.
I'm just curious, in the context of colorectal cancer, one of the things that we talk about is, the potential role of the microbiome driving some of these young onset cancers, with perhaps there being an impact on, for instance, inflammation in the gut and what have you. Tell me about head and neck cancer. Is there anything known as to why younger patients might be getting diagnosed with non-HPV type cancers? It's odd to me.
Yeah, it's a great question. A lot of people are working on it. Folks have hypotheses, but it hasn't totally panned out exactly what's going on there. It does have a little bit more of a tendency towards women, whereas, historically head and neck cancer is a much more common in men than it is in women. But lots of people working on that, whether it's related to chronic inflammation, whether it's related to the microbiome, whether it's related to dental exposure, dental work. So a lot of folks trying to parse that out, because I agree with you, it needs to be identified alongside improving treatment paradigms for these patients, the young ones and the older patients as well.
Interesting. One of the phenomena that was sort of coming around when I was in training, it's 5 years ago was this role of sort of induction therapy for head and neck cancers. And of course, it's really come full circle now to include checkpoint inhibitors and so forth. Tell me a little bit about this and how you apply it, maybe in an HPV-mediated context, maybe in a non-HPV context.
Yeah, absolutely. Induction chemotherapy, as you alluded to, or neoadjuvant chemotherapy, depending on what the local regional treatment approach is, similar to other cancer types where systemic control early on has many potential advantages in this setting. Now, in head and neck cancer, even though induction chemotherapy is quite active in head and neck cancer, both HPV positive and HPV negative, with pretty good response rates, a survival advantage for all comers with local regionally advanced disease remains unproven. There's been 2 randomized trials, both underpowered, but essentially did not show a survival advantage, showing that induction chemotherapy for all patients with local regionally advanced head and neck cancer can't be justified for a survival advantage. That being said, though, there remains a number of potential advantages of giving induction or neoadjuvant chemotherapy. Of course, improving systemic control and debulking the disease early on has potential advantages, and predicting the responsiveness to subsequent radiation treatment. We know for some time in head and neck cancer that the percentage of shrinkage or the response to induction chemotherapy actually predicts subsequent outcome related to radiation. And so, as a dynamic biomarker, where response can be used to select patients, for example, for de-escalated radiation, has been an area of active investigation, active research. And it also remains a key opportunity to evaluate predictive biomarkers and understanding pre and post-treatment to better understand the biology. I'll just add to your question that recently, over this past year, we also saw phase 3 data for neoadjuvant immunotherapy for a subset of head and neck cancer that is surgically resectable. And so that's reintroducing the potential benefit in the immunotherapy era of incorporating immunotherapy in the neoadjuvant or the induction setting as part of the evolving treatment paradigm for these diseases.
That's really interesting. And you kind of alluded to already several topics that I plan to hit on. For instance, the role of immune checkpoint inhibitors, induction chemotherapy, and so forth. And you started to touch on biomarkers. And of course, I think that's something near and dear to many of us in academic oncology. One thing that we've started talking a lot about in the context of colorectal cancer is circulating tumor DNA. How do you think this might fit in the context of head and neck cancer? Can you give us a flavor for that?
Yeah, absolutely. In head and neck cancer, the current landscape is most developed for circulating tumor DNA for HPV-related head and neck cancer. The advantage of HPV-related head and neck cancer is that you have a distinctive HPV DNA that does tend to spill out into the peripheral blood and can be detected using various different blood-based assays. And because of that advantage, as a tissue-agnostic approach, it turns out that a number of HPV DNA plasma assays are actually quite sensitive and quite specific, and a number of them have indeed been commercialized. Of course, not only for detecting at baseline, but also grading responsiveness during treatment, and probably most importantly, in the post-treatment surveillance setting, the detection of HPV DNA in the plasma remains a very important and substantial predictor of developing recurrent disease. There's been a number of trials that have been emerging looking at ctDNA in HPV-related head and neck cancer, using it, for example, as a strategy to de-escalate patients. That was something we saw this past ASCO from the Dana-Farber group, and also using it to early detect recurrence and potentially intervene earlier for patients with minimal residual disease positivity. So that remains evolving, and as many folks are already using it in the clinic. But circulating tumor DNA also has a lot of potential for HPV-negative head and neck cancer. This is actually a bit more challenging to develop because you don't have that HPV DNA that you can track predictably, because the tumors in HPV-negative disease are much more heterogeneous. But there are a number of data that are coming out, both for personalized assays, such as Signatera or some of the other assays that require tumor. Unlike colon cancer, which you referenced, where most patients get surgery up front, in head and neck cancer, many of the patients receive non-surgical treatment, chemoradiation. So sometimes the amount of tumor available to generate a personalized assay is more limited and can be one of the challenges that we see in head and neck cancer. But certainly that also seems to be emerging. And there's also further assays that are being developed for HPV-negative head and neck cancers, such as methylomic signatures and others that may be tissue-informed or tissue-agnostic. And these are also emerging, particularly in the post-treatment surveillance setting, as strong predictors of recurrent disease. So while we're certainly behind some of these other more common tumor types, colon cancer, lung cancer, we're right there with them. And more trials are going to report out, including a number of trials in our upcoming head and neck cancer symposium, where I'll be presenting some data and others in the field will be presenting some data, looking at ctDNA both for HPV positive and for HPV negative to try to improve outcomes for these patients.
That's so interesting. Yeah, I've got to tell you that in kidney cancer, what I deal with day to day is a very sort of low shedding disease, right? So techniques as opposed to ctDNA looking for tumor-informed information, that might be less preferred to something like methylomics, where you might not necessarily be so contingent on what's happening in the primary tumor. So I'm really interested in you mentioning that. Just a point of clarification, this is something I'm trying to wrap my head around. You'd mentioned circulating tumor HPV DNA. I assume this is markedly different from just looking for HPV titers in a patient, right? So is this actually incorporated elements of HPV within the essentially host genome, if you will?
Yeah, correct. This is circulating tumor HPV DNA, and we think of it biologically as a plasma-based tumor DNA biomarker that's specific for HPV-related head and neck cancer.
Got it. And it makes me wonder whether or not this might be applicable in diseases like cervical cancer and so forth, where there's also ostensibly, biology driven by HPV. Is that fair?
Yes, definitely. And in the head and neck cancer field, much of this ctDNA actually was derived from a different viral mediated head and neck cancer, which is less common in the US, but nasopharyngeal cancer, which is oftentimes associated with EBV. That has been a biomarker for quite some time in nasopharyngeal cancer. Of course, in places where EBV-associated nasopharyngeal cancer is endemic, such as East Asia, this has been around for quite some time, but we've been using that in the US, and there's been trials that have used EBV DNA plasma to predict recurrence and stratify for adjuvant treatment, for example. And so now with HPV, it's much more applicable to our US population because the vast majority of our head and neck cancer patients that we see in the US that are viral mediated in the US tend to be HPV related. So having assays that we can use to improve outcomes for that biological subset remains of particular interest for us.
Yeah, no, that's fascinating. By the way, for the fellows listening, there's tons of boards pearls here that Dr. Rosenberg shared, EBV-associated cancers, the role of HPV and treatment associations. So if you're recertifying anytime soon, I definitely think there's notes to take from this conversation, indeed. I wanted to shift gears a little bit. And I mean, obviously, you're a prolific researcher. I don't think anyone goes through their fellowship in medical oncology without recounting these experiences of our head and neck patients really suffering from treatment-related toxicities. It's a real challenge. And I'm just wondering, I know a big body of work that you're focused on is really using multimodality treatment paradigms to perhaps reduce the cumulative treatment burden of patients with head and neck cancers. Can you talk about that a little bit?
Yeah, definitely. Thanks for the question. Before I start going into some of the strategies, I'll just say that head and neck cancer, and this is particularly for the fellows that are listening as well, just in reference to your prior comment, that this is really a multidisciplinary disease. At our center, all head and neck cancer patients are seen up front at that first visit by all three specialties, med-onc, rad-onc, and surgery, because the choice and sequencing of modalities to optimize not only survival, but also functional quality of life outcome is so critical. I think that's probably the biggest takeaway for anyone who treats a lot of head and neck cancer or will be treating a lot of head and neck cancer in the clinic. But in terms of more specific attempts at trying to optimize some of those parameters that you described, we really think about these separately in terms of HPV positive and HPV negative head and neck cancer. For HPV positive head and neck cancer, The cure rates are quite high with chemoradiation, although not for everyone. There's still about 10 to 15% of folks that will develop a recurrence. But for the vast majority of patients, standard chemoradiation is quite a curative therapy, but the toxicity associated with that can be quite substantial. And so there's been a number of attempts to try to de-escalate treatment. Turns out that de-escalating everyone with locoregionally advanced HPV-positive head and neck cancer is not a good strategy because it's not able to select out the patients that really do need full dose treatment. And we have seen some negative trials that show inferior outcomes when everyone is de-escalated. But what does remain promising is, again, trying to select out who the best candidates are for de-escalated treatment. The folks at MSK have hypoxia imaging that they're using in trials that looks quite promising to select for the more favorable de-escalatable biology. At our center, we've been interested in using induction chemotherapy to stratify response and select patients for de-escalated treatment with excellent survival outcomes and reduced toxicity with de-escalated treatment. And more recently, ctDNA that us and other groups, such as the Dana-Farber group, is using. And that also looks quite promising. So again, how do you select the patient who will do well with less radiation versus the ones that really need the full doses and volumes of radiation? And then for HPV-negative head and neck cancer, this is a much trickier disease because already the survival outcomes are not like we want it to be. So trying to figure out how to improve survival outcomes remains an important thing. And using immunotherapy seems to be one of the key cornerstones to that. But these are patients that also suffer from a lot of toxicity related to their treatment. We completed a trial not too long ago that we published this past year where we, in HPV-negative head and neck cancer patients, de-intensified the radiation for responder to neoadjuvant chemoimmunotherapy. And those patients did similar, if not even a little bit better, than the non-responders who got full dose treatment. So something that does warrant further investigation as well. How do we not only improve survival for those patients, but also reduce some of the long-term toxicities?
This is brilliant. I'm taking so many notes as you were mentioning these items. There's so many areas where I think the research crosses over. I already mentioned ctDNA, for instance, and metabolomics and the places where that might apply to kidney cancer. The hypoxia imaging really caught my ear too. Obviously, kidney cancer is a disease highly predicated on hypoxia. So thank you for all of this. We've got about a minute or so I'm going to ask you for a really tall task here. Can you tell us what you foresee being some of the biggest challenges that sort of lie ahead in head and neck cancer? You've already kind of alluded to it with ongoing research, but if you had to pick maybe 2-3 problems, the very most, that we really need to get to in head and neck cancer, what would that be?
Obviously, lots of things to be done, but if I'm going to limit it to just a couple, I would say number one is really trying to improve the survival for HPV-negative locoregionally advanced head and neck cancer. We talked early on about how, of course, we see many of these people that were smokers and drinkers, but also seeing these in younger patients and patients without a history of tobacco use. Some of these are very biologically aggressive, and we need better treatments beyond surgery, beyond chemoradiation, beyond immunotherapy to improve outcomes for these patients and cure more of them. So I would say that's one big area. And the other is, which we didn't speak about so much in this talk, but remains one of the biggest challenges that we see in the clinic, is the recurrent metastatic head and neck cancer patients. This is an incredibly challenging disease to treat, not only with poor survival, but also with substantial impacts on quality of life and function. I mean, these are bad recurrences that cause a lot of pain, functional deficits, really impacts quality of life as well. So developing novel therapies, many of which are currently in clinical trials and many of which are currently continuing to be developed, remains so critical. How do we develop better systemic therapies, better targeted therapies, better biomarkers for recurrent metastatic head and neck cancer to improve their survival and quality of life and functional outcomes? I think those are the two big areas that require the most work at this time within the head and neck cancer field.
That's brilliantly said. I mean, I have to tell you, I could probably talk to you all day about this, such a fascinating topic. It's a very exciting time in the field. Thank you, Dr. Rosenberg, for all your incredible contributions. And thanks for sharing with us your insights on the ASCO Daily News Podcast.
Thanks, Monty. Thanks for the invitation.
And many thanks to our listeners for your time today. If you value the insights that you hear from the ASCO Daily News Podcast, please take a moment to rate, review, and subscribe wherever you get your podcasts.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.